here we have the data, which has been prepared by a large group of very hard-working people from the department and from NEMICS. And then we've been back and forth through it many times with the Brain Tumour Summit Working Party, who are detailed here. So a number of well-known clinicians in the field and people from NEMICS mainly. So, and we have, we can see the names of Ella Stewart and Nora, who have done most of the hard work with the data. And then there's been lots of toing and froing, extra data requested, and trying to get the most relevant and appropriate data together for today. So we're going to talk about the data that we've been able to assess, to put together. So the characteristics of the brain tumour population, various facts about the first step, which is typically surgery, then about treatment planning. Where do patients actually get their treatment? Do they get it in their region or do they get it outside their region? Then later on, we'll have some survival data. I don't think that's in my presentation today. And we'll also talk about supportive and palliative care. Today, I'll be talking about the majority of the data for glioblastoma. And next time, Shui will be talking about oligodendroglioma and astrocytoma, as well as some of the other points, survival and supportive and palliative care. So without further ado, I'll proceed. So obviously, we're all familiar with the optimal care pathway and the different steps that are outlined therein. And I won't go into any detail there. So the data sources in this presentation is listed here. So basically, they're resources within the Victorian governmental systems, and I won't read them all out, but you can read them. So the important thing is that most of the data sources have been able to be linked at the level of each person, and therefore it starts to bring the body of data together rather than being disjointed, and so you can analyze it in different ways, which has been done. So so the linkage, we're told, is reliable. It does give you quite significant information about the patterns of the illness experience and the steps involved. One major limitation is it does not identify out of hospital care. So here we're talking about, obviously consultations, and which might be in the private setting particularly. And it doesn't, and the particular problem here is it does not include temozolomide prescription. And of course, that being one of the major treatments in this group, it's an unfortunate problem, but it's not been possible to link with federal government data such as prescription data. So that we just have to accept that at this stage. Perhaps in the future that will be available. It does include patients who are admitted for intravenous chemotherapy, but obviously that's mainly at relapse, and it's a minority of cases. So hospital coding can be an issue. There obviously can be inaccuracies there. Now it does, this data set reflects the pattern of diagnosis during the period of survey, which was mainly 2016 to 2018. Maybe, forgive me if I'm not quite right on detail there. And to a certain extent, the tumour molecular profile is included in the diagnosis, and that might vary across that time period because 2016 was when the definition for oligodendroglioma became more clear and less based on morphology. So there may be some heterogeneity there, but I don't think it's a major flaw. Obviously, it does if you're trying to look at prognosis within groups. Well, then that's a bit of an issue. But for the greater part, we don't have the numbers that allow that level of analysis anyway. So the other thing is in the Hume district, quite a bit of care occurs across the border in Albury, and that wasn't possible to get admitted episodes of care from there. But we were able to get radiotherapy data and link that in for this group. So that was one that took a bit of extra effort, and that was good to have that in there. So obviously we're all familiar with the different regional cancer services. And anyone who requires a bit of revision, this is the map of them. Now, the one trap in this is the GICS versus GRICS, and many people will be familiar with this, but I was not until about halfway through this process. So Gippsland has got the R in it, surprisingly, and Grampians does not. So it's because it's a Gippsland regional X and Grampians X. So anyway, maybe we could have done it the other way around, but that's how it is. So just watch out for that little trap. But probably most of you already know that. So over this patient group, this is just some of the very basic demographics. So obviously, there's a bias towards older age group in this this disease, or this group of diseases. Like many cancers, males are more heavily represented. That little less chromosomal material seems to count. So obviously, it does affect all different groups in society, and I don't think that it's a big discriminator between different socioeconomic groups. And many of these patients are otherwise pretty well, as you can see with a Charlson comorbidity count of 0 for the majority of cases, and then obviously a spread across other groups as you would expect. So the tumour characteristics have been decided on the basis of the ICD-10 primary diagnosis, and then we went through it and decided how we would group them. There were a very large number of small groups, and they're grouped in morphology, and it's very extensive, the number of malignant tumours that are represented there in small numbers. But each of them had numbers that were far too small to benefit or merit further analysis. So we've ended up with these 3 main groups. And really, I should clarify that it really perhaps should be called glioblastoma, oligodendroglioma, and astrocytoma, because anaplastic astrocytoma has been placed in that 3rd group. And in the majority of cases, the diagnosis on the basis of histology, but some are just clinical diagnosis in patients who did not go to biopsy. So we just start off looking at the whole group initially, some of the data pertaining to the whole group. And surgery is obviously after diagnosis. Surgery is the first step that we were able to look at. Obviously, diagnosis often takes place outside the hospital setting, and the patients come into hospital after the diagnosis has been made, although some diagnoses are made in the emergency department. So here we're talking about all brain tumour surgery, not just malignant brain tumours. So the benign tumours are included here in this graph in the mauve coloured sector within each of these columns. So basically, like malignant brain tumours, which is the main subject of today's malignant primary brain tumours, the main subject of today's meeting. We've got benign brain tumours, i.e. meningiomas, etc., and then secondary brain tumours, which are not specifically the focus of our meeting today over these 2 sessions. So we can see here the spread of brain tumour surgery that's done across Victoria. There are 5 public hospitals active in adult brain tumour surgery work. Obviously, RCH is very active in the paediatric age group, but it's not part of this summit because it's a completely different group of clinicians. There are some private hospitals that are quite active as well, 3 larger ones and then some smaller contributions. Some of the smaller ones, if I'm correct, are linked closely with public hospitals and some are not. So that's something. So some of them are quite small volume and some of them would be standing on their own. So the first analysis that's been performed, or the first that we're presenting, is the mortality within 30 days of the first major surgery. There's a large group of patients across the whole group with malignant brain tumours. And you can see that there's one campus which lay outside the analytical curves that are presented here. So we've got 30-day mortality on the y-axis and the number of patients at each site of surgery across the x-axis. So obviously one unit has about 250 cases, and then we have quite a broad spread down to very tiny volumes. So one of the concerns is the possibility that patients in small centres might be at risk. And I guess one can derive a certain amount of reassurance by the fact that the small centres sit firmly on the 0% line in this graph, or very close to the 0% line anyway. So that's interesting and reassuring to a degree, because that was one of the areas that we did discuss. as you can note, there was one outlier noted, and that has been referred to DHHS, who have been working with the hospital in question. And we're not going to go any further into that. So now in the centres that had very low volume for brain tumour surgery, there was some interest as to whether this was good practice or not. But when we looked into it, we found that the vast majority of the cases here were actually not brain tumours. They were skull tumours of various sorts. You can see benign neoplasm of maxillofacial bones, benign neoplasm of craniofacial bones. There were a very small number of brain tumours. There were a couple of 3 secondaries in the private hospitals and a couple in the private hospitals, the skull lesions. So really, we're not really talking about the very, very tiny number of intracranial surgeries done, but you can still ask the question as to whether that's appropriate in a hospital that has so little exposure to this form of surgery. And of course, it's not just the expertise of the surgeon, it's the expertise of the nursing staff in managing post-op observations, the availability of post-op CT at short notice should there be a complication, and a whole number of other systems that are required to support this type of work. Anyway, so we move along. So this is a slightly complex graph. So we're talking about here the X of resonance of the patient. So which X the patient comes from, not which X the treatment was undertaken in. And we're analysing we're looking at median length of stay. And basically for major surgery, the median length of stay was 7 days. And surprisingly, for biopsy alone, the median length of stay was the same, which you just look at that and you think that's a bit surprising. But anyway, that's how it is. And the graph, the y-axis here is the number of patients whose surgical episode was longer than the median. So in other words, 8 days or more. So you can see there's a scatter there. Most of the scatters lie within the 95% confidence interval, but there was one hospital that lies below that line, and there are one region which lay below that line, which of course is a positive phenomenon in that circumstance. It's probably the main thing, and then one country region which sat a bit high on both those lines. So that's of some interest and does make one wonder about logistical factors. I don't think we could really say that's a proxy for quality of care, although that might play into it a bit. So anyway, this is talking about which campus the major surgery was done at. So you can see there's a lot more data points on these graphs. And again, we've got these curves representing the 95% confidence interval and the 99.8% confidence interval. So once again, there's one large provider sitting with a tendency to have a low number of patients having longer lengths of stay, which is obviously a good thing. And we've got one large provider sitting higher above that curve as well. So that's might indicate lower levels of efficiency. So but you can see here the effect of whether the patient's brought in as an emergency or whether they're a non-emergency admission. And of course that fits with common sense. So someone who comes into the ED sick is going to stay longer. There's not going to be a plan to get them to surgery straight away. So there's going to be a delay in getting scans, making the diagnosis, and then planning surgery, as opposed to the non-emergency admission when that can all be planned before the patient comes into hospital and they can go straight to surgery. So of course you immediately slice a few days for assessment and preparation of the timing. And they're also, the emergency ones may have a slightly greater tendency to be sick than the non-emergency ones. So I think those funnel plots have got a few interesting points there and perhaps some opportunities to improve. So this is looking at the group who didn't have major surgery, they had biopsy alone. So again, for the emergency admission, the median length of stay, actually 10 days, which is ever so slightly higher than the length of stay for a craniotomy, interestingly. So it tends to make one think it's organisational and patient-related factors that tend to determine the length of stay. And then for the non-emergency admission, you do see a shorter length of stay of 5 days, reflecting the fact that patients should get over a biopsy quicker than a major craniotomy if they're not coming in sick and all the rest. So, but once again, there's quite a scatter there, and perhaps there's some within the ICSs, there may be some work to be done about whether certain providers could improve their efficiency and thereby improve logistics and resource utilisation. So that's what we're able to garner from surgery. There was other material that was discussed and at the working party level and felt to be of less interest. So, now this again, we're now talking about multidisciplinary meeting and treatment planning. So this is across the whole group again of all the malignant brain tumours. So this is just in public. There's no opportunity to get the private hospital data on this particular question. Some private hospitals do have an MDM, some don't. That again is a matter that could be of some interest to discuss within the ICSs. But anyway, so some networks have had more emphasis about this than others. Perhaps in some institutions, there's a feeling that the routine cases where the diagnosis might be GBM and the treatment is almost always STUP, depending on patient fitness. In some of them, there's a feeling that these cases need to be discussed at an MDM, and there is some merit in that idea, but it's not. It's not in the advised optimal treatment plan, but that's a point of interest perhaps that could be discussed when these treatment plans are looked at again. Obviously, communication to the GP is crucial. So in some institutions, this was effectively captured in the medical record, and in other institutions, this was not captured so well. And again, it begs the question of, is this communication occurring with efficiency or not? Or perhaps it is occurring and there's a higher proportion of private patients and the letters coming from the private rooms or from a point in the system which has not been captured. So, but I think this is obviously a crucial point in the patient experience. We're hearing about communication, collaboration and coordination, and something to think about. So this is a broad sweep of treatment paradigms across all the groups, and we'll come to each group in turn to look at it more carefully within each group. So it's a lot of data on this slide, and I don't think I'll dwell on it greatly, but you can see the majority of patients had surgery. A substantial proportion had major surgery, i.e. craniotomy and resection, and then, but also a significant number had biopsies alone, smaller procedures, and then other procedures which might include shunts and a whole variety of different operations are appropriate in this patient group. Now, radiotherapy was used in the majority of cases, but again, it varied across different patient groups, and there are many clinical parameters that would lie behind this, and we come to a bit more detail later on. Chemotherapy, here only capturing the intravenous chemotherapy, which, as we said previously, is not the treatment of choice for the majority of patients. So again, we just have to accept that the temozolomide data is not here. And there are some patients, and we all have patients that we've treated who would not be appropriately treated with any of these modalities. They may be very old and in poor clinical condition, and a palliative approach might be taken from the get-go, or there may be other reasons for this decision, such as patient preference, etc. So it is interesting to know where patients are treated. So in regards to major surgery, we see, so we look down the left-hand side, we're seeing the X of resonance. So this is where the patient lives, and then the other axis, the x-axis, sorry, is the X of surgery. So so if you go down obliquely across the major X's, NEMICS, SMICS and WICS, you see the proportion of the patients within that catchment that are treated by our hospital in that catchment for the surgery. So it is notable that NEMICS has a lower proportion, and that's probably because they only have one major public hospital within that catchment, whereas SMICS, there are two major public hospitals within the catchment, and in the Western X, there are three major public hospitals within the catchment. So I think that, yeah, that's just, oh, sorry, two major hospitals within the catchment, sorry. So, and then of course, you know, where do the country patients go from the different country centres. None of them are operated in their own centre, except perhaps a couple, a very tiny number at Geelong. So you can see if you take the time that there are some patterns of patient flow there. And of course, just to pick one out that would know about is the Gippsland patients do tend to come to Smiths in the main, but still quite a significant number go to central hospitals. So of course, actually this graph doesn't just include public hospitals. I've made an error in my explanation there. It does include private hospitals. And again, there's a preponderance of private hospitals within WIMIX, within the Western and Central ICS. So a large proportion of patients did have surgery outside their ICS. As you can see, 44% local, almost 55% having it outside. And that reflects the pattern of Victorian practice. Really, GPs and clinicians are free to refer to whichever provider they wish to. So in radiotherapy, there's provision of radiotherapy in the regions, and that's quite a big change over the last. If we'd done this survey 20 years ago, there would be no radiotherapy in the regions, and now this is quite well established and seems to be working very well, from my impression. And you can see that there's been quite a large take-up in this regard. And the radiotherapy, yes, some of the patients who had their surgery in another ICS, there's a bit more of a tendency for them to have their radiotherapy within their home ICS. So again, there may be some, they may not necessarily follow patterns of a linear nature. So but now we move on to data about the glioblastoma group, and I better keep moving, I guess. So we've come to treatment, and it's again a very complex graph. So we've got ICS of residence across the top, and then the patterns of treatment down the side. And there are some variations that are coloured here in the slide, and some of them, many of these are not significant, or sort of, no, they are coloured because they are of some significance statistically. And yeah, so there's a little bit of a pattern there. You see a couple of country centres aren't getting as much IV chemo, so that may imply that there's less therapy at recurrence, because that's where intravenous chemo is mainly used, and so on and so forth. But yeah, again, we've got this limitation with temozolomide in this data set. So there is a difference by age, and we can see that the older age group above 70 are less likely to have major surgery than their younger cohort. They're less likely to have radiotherapy. Only about 50% of them are deemed appropriate for radiotherapy, and intravenous chemo is also less frequently used. So in all, the treatment intensity is less in the elderly, which is appropriate for those of us who are, well, it's quite appropriate, yeah. No surprises really. So we attempted to look at radiotherapy to see whether it was radical or not radical, and we broke it up according to the number of fractions. But in later discussion and analysis, it proved it wasn't quite so simple, because some patients are getting higher doses of radiotherapy in less fractions. So this analysis is of some interest, and there are some different patterns being used in different parts of Victoria. And there are arguments for and against this when we've discussed it within the working party. So I don't think any of these so-called outliers are necessarily representing erroneous practice, but it's a difference, it's a variation in practice for sure. And one of our largest radiotherapy providers does use a different pattern of radiotherapy than some of the others, and that may be subject for further discussion. But in fact, when you look at the data, there's no clear scientific data to say one method is worse or better than another, and there is some room for controversy. So I think sometimes different treatment paradigms have got equal virtue. So if we look at the number of patients who received radiotherapy, I found this graph quite reassuring in that basically we're seeing there's no part of the service where there's a major difference that lies outside the reasonable error bars. So you can see the error bars on this graph. Whilst there are some groups that have slightly lower rates of radiotherapy usage, basically, if you include the error bars, which is appropriate, there's a relative uniformity of practice. So one can talk about some small points there, but really, as I say, they're all within the error bars. So there's basically not significant variations here. So we're not seeing country patients missing out on treatment, which might be something you worry about. And there's no real pattern of that. Even the Hume one is sitting obviously right on the edge of the error bar there, but it's, as I say, statistically, you'd expect someone to be sitting out there just by the definition of 95% error bars. So timeliness of radiotherapy. So this is mentioned in the treatment optimal care pathways. And there was quite a lot of debate about how relevant or important these variations are, but there are some variations here. And it's not really surprising to see that regional residents who are referred back to their regional radiotherapy centre might incur a little bit more delay than those who are treated locally. Obviously, just the whole process of transferring care between one institution and the other may lead to some delays. And we do see that there's evidence of a slightly delayed start to radiotherapy in that setting. Again, the data, the data does not suggest, the most modern data does not suggest any real advantage to starting your radiotherapy at 4 weeks or at 6 weeks. So I don't think this is a huge clinical concern. It might be something that patients might find frustrating. They have to hang around waiting to get on with the next step. But nonetheless, there is some variation here, which is not huge, but there is some. And of course, if the patient was in the tail of, one thing that we all need to understand is that there's a tail at the outer end of this. Some patients are just not fit to get on with radiotherapy because of the severity of their illness and their ability to pick up again after surgery. They may not be fit for radiotherapy within the desired time frame, and one just has to accept that there's going to be a tail. But perhaps some of that tail is just due to relative inefficiency and could be a source for dissatisfaction and perhaps even a low level of clinical concern. One thing that we do need to remember is it's not just radiotherapy that's starting at this time, it's also the concomitant temozolomide, because almost all patients have concomitant temozolomide as per the Stuhl protocol at the same time as radiotherapy. So there are some variations in the data that we'll be talking about later. So the first one doesn't require further discussion. The second point, we've discussed a little bit that some of the low volume surgery campuses actually aren't really doing this sort of surgery at all. There's just a bit of, some of them are coding issues. The very small ones it's coding. So, but there may be some issue in the groups. Hospitals are doing 10 to 30 operations over a 3-year period. That's still very low volume. And that might be something to consider. There is variation between campuses and length of stay, as we saw before, and that may reflect relative efficiency of making decisions, getting the scans, getting patients sorted out, getting them to surgery, and so on, and then getting them off to rehab, those that need rehab afterwards. There's a variation in timeliness of radiotherapy, which was not a large magnitude. And I don't actually believe that there is variation in delivery of radiotherapy for the over 70 because they all lay within error bars. So I don't think that's statistically correct, but yes, there is some variation there that, but I don't think it's statistically valid. And so some of the questions that we're thinking we might address in the next part of the seminar are outlined here, and we'll come to them again. So perhaps since I've gone for a fair bit of time, we might stop it there and come back to that soon.
Yeah. So I think, sorry. So in terms of the first data slide, this is where we are looking at now survival for all cancer patients. And in this slide, as you can see, we're looking at how the different groups do based upon the types of tumor that they are. So this is now no longer looking by regions. I think there's not much that is very controversial here. I think we can see that glioblastoma, which is the black line, has the worst survival overall, which is what you'd expect. In the red line at the top, you have the oligodendrogliomas, which do very well and are very chemo and treatment responsive. So they do the best. in survival. And then in the middle, we have the astrocytomas that are not oligodendrogliomas, and they're intermediate. The other line there is other tumors, which is really kind of a whole hodgepodge of tumors. We've got medullos, ependymomas, and they seem to, collectively, these very different histologies also seem to do so intermediately well for survival. So now what we're looking now is just drilling down to glioblastoma in particular. And then we're looking at how you do if you belong to a certain X of residence. And I think if you look at that Kaplan-Meier plot, you won't really think that was any much difference. There's no statistical difference across the different groups. But I guess, so, obviously this is a very important outcome. So we did want to drill down and see whether there was any variation across the X. I think the next slide is probably puts it in a way that's a little bit easier to follow, and that you can see that that central vertical line is hazard ratio of 1. And if your confidence intervals crosses that, essentially there's no significant difference. But I think that perhaps, it was worth pointing out that there might be some numerical differences. In some of the X's, you're sort of a bit left of the line. So, maybe are doing a little bit better. And then in some, if you're, to the right of the line, maybe a little bit worse. But I think these are very small differences, and whether they are truly different or not is unclear. However, I think that it may be that for the groups that belong to different X's, this may or may not be something that may be worthy of some discussion. So really, that's about survival. I think that we weren't going to spend a lot of time on that. I think the next part is about supportive and palliative care. We have more data that we want to discuss. I think that much like we've discussed, this is the best data that we have. It may not be absolutely perfect, but I think there are some important trends and patterns that we might want to look at. I'd argue that, we've not made an impact on survival for 30 years through, potentially with medical type interventions. And one way to perhaps improve outcomes of patients is to make sure that the evidence-based things that we know help people are well implemented. And supportive and palliative care is certainly one of those things. So the first thing we're looking at here is really about the use of a validated supportive screening tool in patient management, really. Now, this was data that came from a survey that was done in 2017. And it mainly was in public hospitals. There were a few private hospitals. And what the data shows us is that overall, there was about 34% of patients that were in the survey where the use of a validated screening tool could be shown. Now, at the time, the DHHS guideline was that the aim was to have 50% of patients at least having such documentation. And very clearly, we see a variation there in that we don't see with the WIC mix, there isn't any documentation. Now, it's important to say that this does not mean there was no supportive care screening, but that the way that is done there is not to use one of these tools. And that was something that had a lot of discussion and may generate a lot more discussion there. So I think we can say that approximately half of the X's that we see there, we see that at the time we're above what we needed to be. And I believe that subsequently last year, the required rate was raised to 80. So it will be interesting in the future to see whether we hit that mark or not. So the next one that we wanted to discuss really was about whether referral and use of palliative care support is being done as proactively as is optimal. And so this is now looking at this about whether there is documentation of patients having had some sort of referral to inpatient palliative care, outpatient palliative care, and community palliative care. And it's important to say that this data set is incomplete insofar as the fact that our ability to capture the community palliative care is not absolutely perfect. So you could make the statement that probably that there is there is going to be more activity than we are seeing, but we cannot tell you exactly what that is. And the data that's looking here is we're looking at the 11 months of, we're looking at 11 out of the 12 months before the patient died. And we're particularly looking at everything aside from that 12 months immediately prior to their death. So I think that what you can see there is that across the board, about 50% of patients have documentation of such referral care. I would say, looking at the funnel plot, that you see some minor up and down, but nothing that is a huge outlier. And we may or may not want to discuss that, whether a 50% or better referral is adequate in itself. But probably from a variation point of view, we're not seeing very huge changes. Now, this is then moving. Remember, I said that was the 11 months. Then we look at the last month of life for patients. And we are looking at, this is really about acute-based hospital care. It's not, strictly speaking, palliative care. And I guess the theme here is whether, is there an undesirable level of admission or aggressive treatment in that last month of life. So the data here looks at a number of parameters. There's emergency department admission, there's ED presentation, a prolonged inpatient stay in an acute hospital, and ICU admission. And when you add it all up, you can see that approximately, just under half of patients have some sort of presentation to an acute hospital in that last 30 days, really. Now, I'm not saying that this is not inappropriate, that even in the last month of life, certainly in our practice, there are people who need to come in for unexpected things, say like an unexpected seizure. I think we see in the cells there are perhaps some variation there in terms of for certain of those parameters, that some X's are a little bit higher, some a little bit lower with that. I think perhaps the funnel plot that we're coming up is a good way of looking at that. And again, you see that it's approximately just under a half of patients in each X have to go to an acute hospital. Within the funnel plot, everyone's basically somewhere in that 2 standard deviations, a little bit higher, a bit lower. So again, aside from the absolute level, I don't think from a variation across X point of view, there is necessarily a huge difference in my opinion. So that's concluding the part about supportive care and palliative care, and obviously that will be one of the topics we will discuss a bit later. The next part that we're looking at really is about some of our perhaps other common types of gliomas, but with different histologies and with different grades. So we're looking at the oligodendrogliomas and the lower grade astrocytomas, so not the GBMs. And I must say, I think this part of the data becomes quite granular and quite complicated. But let's go through it slowly, and then happy to clarify anything as we go along. So we're starting now. So starting off first with the oligodendrogliomas. So obviously these are a very distinct group of patients, and the classification of this has changed in recent time, becoming more of a molecular classification than a morphological, than a histological classification. And what we start off with is we're looking at basically the treatment of these patients in the first year of their diagnosis by their X of residence. So not necessarily where they were operated on, but this is their X of residence. Now, we've previously seen some data in the last week about how, particularly with surgery, can very occasionally track differently. But if you look at the oligodendrogliomas in the X's of residence, if you look at the different X's, and the regional ones have been combined because of just purely for numbers, I think we can say that across the board, there's almost all patients have some sort of surgery, and most patients have some sort of major resection. Approximately 43 thereabouts % of people get some form of radiotherapy. And then for the chemotherapy data, we again come up against the limitation that we've already seen, which is the fact that we really can only capture IV chemotherapy at this point in time. which is quite a problem because in fact, there's probably only 1 or 2 IV drugs that we would use, and they're not necessarily the most active. And it's the lack of PBS data for temozolomide that is particularly problematic here, really. So when we look at this data set, I think that the main conclusion we have is that the patterns of, I guess, treatment use is not really very different across ICSIS or metropolitan versus regional. So to drill down a little bit more on this, we're now looking at the oligodendrogliomas, but breaking that down based on the grade of the tumor. So we have the lower grades, the grade 2s, and we have the higher grades, which are the grade 3s. And I think if I was to go down those columns, I'd say that if we look at the grade 3s to begin with, you have most of them have some sort of a resection or some sort of surgical intervention, and it's usually some sort of major intervention. I think that you find that 72% of these patients have some sort of radiotherapy in the first year. Just for your reference, looking back in the glioblastoma data that we saw last week, which is the more aggressive version, that the use of radiotherapy in the first year is about 68%, so we're at least tracking as much. And then with IV chemotherapy, we see 22%. I've been somewhat inclined myself to interpret that to say that this might be PCV use, because that's a multi-agent chemotherapy that does have vincristine, which is intravenous, but I don't know that for a fact. And again, can't tell you whether people are getting oral chemotherapy by itself, really. So that's on the anaplastic grade 3 side. On the grade 2 side, we see, again, most people are being managed quite aggressively surgically. There's about a third that get some form of radiotherapy relatively early on. And I think this is a complex area which we're going to drill down a little bit more as we start to look at some of the other factors that might impact on the decision to irradiate and or give chemotherapy. So that last slide, we were looking at the oligodendrogliomas, looking at them in terms of their grade. And now here we're trying to perhaps split them into a sort of a more sophisticated kind of way into risk. So you can see that if you look at patients who are more than 40 versus less than 40, that the ones who are more than 40, that there is perhaps still a lot of surgery, perhaps slightly less in the way of major surgery. 47% get some form of radiotherapy in that first year, and 8% with small absolute numbers having some sort of IV chemo. And you could argue that the more than 40s, particularly if they are sort of grade 2s and not completely reset, might be a high risk group. If you look at the ones that are less than 40, again, I don't think we see very huge differences that are there based on that split of age. So that's the oligodendroglioma data. This is now looking at the astrocytoma, so I guess the non-GBM, IDH1 mutant, non-1p19q code deleted. And this has a number of histological subtypes. They've all been grouped together. It's a very similar format to the oligodendroglioma data. So again, if we look across the ICSIS with the metropolitan and also the regional ones, I don't think that we see much that is a variation across the regions. Again, mainly people are, most people are getting some sort of surgery. About 60% have, on average, have some sort of a major resection. About 59% have some sort of radiotherapy, and then a small group having some IV chemotherapy as well, but not, I think, with any major differences that are there, really. So now we are looking at this, looking at 1 year and but doing the split on the grade in astrocytoma. So again, grade 3 versus grade 2. If we look at the more aggressive sort of grade 3 grading, you see that, again, most have surgery, about just over half have some sort of major surgery. 82% get some sort of radiotherapy in that first year, which I think is a reassuring figure. And there's, again, a smattering of IV chemotherapy there. And just to reiterate again, we don't have that temozolomide data, unfortunately. When we come down to the grade 2 astrocytomas, we see that the rates of radiotherapy are almost half the grade 3s, and also that some chemotherapy, that's a bit of IV chemotherapy used there as well. So I think that that is a complex area in terms of the lower grades. I think that this slide is just to show that if you're looking at the radiotherapy that was delivered, the majority was more than 20 fractions rather than less than 20 fractions. So I guess we use this to denote a relatively aggressive radiotherapy. We've interpreted this to be a relatively aggressive radiotherapy schedule. And then here again, with the grade 2s, we're trying to look at how they go in terms of risk. There's the more than 40, and then there are those for whom they've not, whether they've had the biopsy as their only treatment. And there was a small number of patients, I think only a handful here, who had gemcitabine sort of histology as potentially a more aggressive tumor, a more aggressive group. So if you have one of those and are sort of broadly high risk, we see that the surgery part, there's still most people are getting some surgery, and mostly it's a major sort of debulking. If you're high risk in that time period, 2013 to 2017, arguably a time of some flux, the use of radiotherapy was 45%. The use of IV chemotherapy was 13%. If you were then low risk, you can see that there was perhaps slightly lesser use of some radiotherapy, and similarly with regards to the chemotherapy there. So I think we kind of burned through that quite quickly, really. But I think that in summary, these are the key points that we had for discussion and perhaps for commentary. That perhaps the rate of supportive care screening is low, but I think there are caveats to that as we discussed. There was definitely sort of systematic variation in use of the validated tool, which was how the evidence of supportive screening was measured. We can see that the target itself shifted over that time. And we can certainly talk, as I said, about both the absolute amount and the variation that we see. I think we also start to look at the use of the palliative care, which again, I think it's going to be a discussion perhaps about the absolute level and the variation. If we're looking at the issue of early referral, into palliative care, we see that rate is at least 50%, but I would again bring the caveat about the fact that we do not know that there's some gaps in that data. I think I'll be interested to hear from people whether there's any concern that about 45% of people needed some sort of acute hospital admission. And if I was to pull out two of the factors, I think 16% having a more than 2 week stay is interesting, and 6% having going to ICU is also interesting. I'm not saying it's inappropriate, but I think it is very interesting. For me personally, I was a bit more reassured. I thought the data about looking at grade 3 gliomas suggested that patients were being managed relatively aggressively and I think appropriately in terms of having, surgery and radiotherapy, most of it in some radical way or a high fraction way. And, I think that the data about the grade 2 gliomas is definitely limited. I would say that going forward, there are many additional information we should try perhaps to make sure that we have. I've listed a few there. We've already talked about the oral chemotherapy, but this data, for example, the split between astrocytoma oligodendroglioma was entirely histological. Actually, I think that is true, but I don't think we had detailed molecular pathology data. And I think that when we start to look at the risk stratification, we had the age, but we didn't perhaps have actual gross tumor resection. And so the variation data, I think I sort of mentioned in passing that there's some variation in practice, and our data is predominantly in the public sector, and there's perhaps some variation there in the palliative care in the prior 30 days as well, but not big differences, I don't think. I think that's the data presentation, and I might throw back to Veronica now.